Welcome to this video on Succinylcholine. Succinylcholine is a depolarizing neuromuscular blocking drug. It is a partial agonist of the NM receptor. It produces persistent depolarization of the neuromuscular junction, and this locks the voltage-sensitive sodium channels at the perijunctional zone in the inactivated state. There is a failure of action potential generation and propagation, and the end result is neuromuscular blockade. Now, in previous discussions, we figured out that cholinesterase enzyme is of two types: acetylcholinesterase enzyme, which degrades acetylcholine, and plasma cholinesterase, otherwise called butyrylcholinesterase, otherwise called pseudocholinesterase enzyme. Now, butyrylcholinesterase is the enzyme which is responsible for degrading succinylcholine. Now, most people would have properly functioning butyrylcholinesterase, and this is called typical butyrylcholinesterase or typical plasma cholinesterase, or indeed typical pseudocholinesterase. However, some unfortunate people may have pseudocholinesterase which doesn't work properly, or they might have a deficiency of pseudocholinesterase. Now, such patients are said to have atypical pseudocholinesterase. Now, typical pseudocholinesterase will be able to degrade succinylcholine efficiently. If a patient has typical pseudocholinesterase, 90% of muscle strength will return following administration of succinylcholine in just 9 to 13 minutes. And this explains why succinylcholine has such a short duration of action. However, in certain patients, as we discussed, there may be either a deficiency of pseudocholinesterase or there may be atypical pseudocholinesterase. Now, atypical pseudocholinesterase will not be able to degrade succinylcholine quickly, and in such patients the action of succinylcholine can persist for up to 8 hours. Since obviously the diaphragmatic muscles are paralyzed throughout this time, the patient will develop a condition known as succinylcholine apnea. The treatment of succinylcholine apnea would be the administration of positive pressure artificial respiration with oxygen. The airway should be maintained patent until recovery of normal respiration. Now, is there any way to find out beforehand if the patient has got typical pseudocholinesterase or atypical pseudocholinesterase? Well, the answer to that question is yes, and that is by finding out the dibucaine number. So what exactly is dibucaine? Dibucaine is a local anesthetic agent, but in addition to local anesthetic agent activity, it also has another additional property. It is capable of inhibiting the activity of typical pseudocholinesterase. It fails to inhibit atypical pseudocholinesterase. So normally dibucaine will inhibit 80% of typical pseudocholinesterase, and this is referred to as the dibucaine number. So anything above 80 is considered to be normal and is indicative of the presence of typical pseudocholinesterase. So what we do is we collect the patient's plasma, and the patient's plasma should contain plasma cholinesterase enzyme. We add dibucaine and we measure the ability of dibucaine to inhibit plasma cholinesterase. If the ability of dibucaine to inhibit plasma cholinesterase of the patient is more than 80%, then we say that the dibucaine number is more than 80, and this patient has typical plasma cholinesterase. On the other hand, if the ability of dibucaine to inhibit plasma cholinesterase of the patient is less than 20%, then we say that the patient has got atypical pseudocholinesterase. And this patient is at high risk of developing Succinylcholine apnea. So among the adverse effects of Succinylcholine would be increased potassium, hyperkalemia, increased intraocular pressure, intracranial pressure, intragastric pressures, and so on, increased temperature, malignant hyperthermia, myalgias, and of course Succinylcholine apnea in certain patients. Now let's move on to the other adverse effect of Succinylcholine, namely malignant hyperthermia. To understand the pathology of malignant hyperthermia, we need to understand the steps in normal excitation-contraction coupling in the normal skeletal muscle. Although discussed in detail in previous videos, I will quickly go over the basic steps. So this is the cell membrane of a skeletal muscle. As you can see, there is the pentameric NM receptor, and when acetylcholine binds to the NM receptor, it opens up, causing cations to enter. This changes the voltage of the cell, makes it less negative, and these changes in voltage stimulate the voltage sensitive sodium channels in the perijunctional zone. They generate action potentials, and the action potentials get propagated throughout the cell. The action potentials will then change the voltage of certain specialized voltage sensitive calcium channels present in the T tubules. These are called dihydropyridine receptors and allow calcium to enter. The dihydropyridine receptors allow calcium to enter the cell, and when this happens, the storehouse of calcium in the cell, namely the sarcoplasmic reticulum, gets activated, and there is a receptor on the membrane of the sarcoplasmic reticulum called the ryanodine receptor. That gets activated and releases calcium into the sarcolemma. The release of calcium into the sarcolemma has got important consequences. Now, if we look at a skeletal muscle, we know that it consists of myosin, indicated in blue, and actin, indicated in yellow. And in the relaxed state, the myosin heads are prevented from interacting with actin by tropomyosin, represented by the black lines, and the troponin heads, represented by the black circles. Now, this is a sarcomere. When calcium is released in large amounts from the sarcoplasmic reticulum, they bind to the troponin heads and cause lateral displacement of tropomyosin. This creates the opportunity for the myosin heads to interact with actin, and when they do, a power stroke results, and this results in shortening of the sarcomere. And when this happens to millions of sarcomeres throughout the muscle contracts as a whole. Now, malignant hyperthermia is easily one of the most devastating anesthesia-related complications. It has been and continues to be a life-threatening complication of anesthesia, and it is very essential that diagnosis of this condition is made very, very promptly and treatment is begun in a very timely fashion. Now, malignant hyperthermia occurs in patients with a genetic defect. To put it in a very oversimplified manner, in most patients, the genetic defect is in the ryanodine receptor 1 gene. This results in unregulated release of calcium from the sarcoplasmic reticulum into the sarcoplasm, and this in turn leads to uncontrolled contractions and the typical rigidity of the skeletal muscles in malignant hyperthermia. Now, the calcium pumps and transporters in the skeletal muscle will try to overwork in an attempt to reduce the levels of calcium in the sarcoplasm. Now, these mechanisms need plenty of ATP, and to supply the required amounts of ATP, all metabolic pathways go into overdrive, generating massive amounts of heat, and this results in the hyperpyrexia of malignant hyperthermia. We talked about the great importance of very prompt and early diagnosis of malignant hyperthermia. These are some of the early signs of malignant hyperthermia, and probably one of the earliest signs would be an increase in the EtCO2. Now, which other drugs that cause malignant hyperthermia? Well, general anesthetic agents like ether and all the volatile liquid general anesthetic agents like halothane, enflurane, isoflurane, desflurane, and sevoflurane can precipitate malignant hyperthermia in genetically predisposed patients. In addition to these drugs, the depolarizing neuromuscular blocking agent, namely Succinylcholine, can precipitate malignant hyperthermia with explosive onset. Dantrolene is the only medication that has been shown to be effective in reversing the symptoms of malignant hyperthermia. It is a directly acting skeletal muscle relaxant.